I'm very happy to be here today, and I've been asked to talk about caregiving, people that are the caregivers, and from a research perspective. And I know you're all thinking, okay, there's going to be stats, and there's going to be bar graphs, and there's going to be arrows. And I just want to let you know and assure you the arrows are in color, so we should get through this just fine. Okay. So just a little bit of an overview. We'll talk about family caregiving, what is being involved in that in the U.S. and in Utah, and the value that caregiving brings to our healthcare system and to our country, the effects on the care recipient, the effects of caregiving on the caregiver, and that interdependence. And then I'd like to talk about some exemplars from our own research and the needs for changing healthcare, and end with a way that we can begin to talk about, really generate a new discourse about family caregiving across the lifespan and normalizing it. So the majority of you are in this room are currently caregiving for a family member or friend or have done so in the past few years. There are 44 million US adults that serve as family caregivers. Healthcare professionals are no longer the main provider of patient care, and when I see that, I find it shocking. And also, you need to know that these services that family caregivers are providing has a price tag or a value of $470 billion. Individuals provide care across the lifespan, and usually adults spend about 5 years caring for another family member, and that is over 8% of their life. And some of you may be thinking, who's going to care for me? Because the family caregiving pool is shrinking as we have our baby boomers aging. And let me just stop for a minute and define what we mean by family caregiving or family caregivers. Family caregivers is who you or the care recipients identifies as their family member. And we're talking about unpaid caregivers. So this could be a friend, this could be your biological family, could be a neighbor. So thinking of terms, sometimes you hear the term informal, but we'll use the term family today to cover that. So Utah caregivers are also doing their part. 1 in 5 Utah adults are caregivers. They provide about $4.2 billion worth of care, and 25% of Utah caregivers have provided care for at least 20 hours per week. So they're doing that half-time. And many Utah caregivers are working. So this slide is from AARP, and we can begin to understand the value or the price tag of the $470 billion worth of care that caregivers provide in this context. So if you look there on that should be 470, not 47. We all know that Walmart makes more than $47 in their sales of it's our country's largest company, and that should be $470 billion. Family caregiving provides costs that are more than Medicare spending and more than total out-of-pocket spending for health care. So Lynn Frisch-Freiberg from AARP Public Policy Institute likes to challenge audiences to imagine if U.S. family caregivers went on strike for a day. Don't think about doing that, but in our what would our healthcare system do? What would our long care services centers do if they had to step in? They just could not possibly come close to covering the services that family caregivers provide. So if family caregivers went on strike, what are the kinds of services that would go unaddressed? Well, here's a list of the kind of services that family caregivers provide and how we estimate that value. And there's many things on here, from basic needs to medication management to coordinating with the care team, getting medical equipment in the home, et cetera. So there's a variety of things that family caregivers do, from simple tasks to very, very complex tasks. So given that our healthcare system is so dependent on family caregivers, of course, caregivers are supported in every way, right? We all know that. Not. So we know that caregivers are marginalized and really not given the preparation they need. So what our healthcare system does is simultaneously depends on family caregivers and our payers too, yet marginalizes them. So 2/3 of family caregivers report not being asked what they need to help their care recipient. 84% report that they need more information or education, that would be helpful to them. They're often excluded from treatment decisions. Nearly half report they've had no choice in the role, they just stepped up. And this was talked about earlier when we had the conversation about HIPAA during the panel, that increasingly caregivers report barriers to communication because we're so focused on patient privacy that they're not invited in when they really need to be provided in because they are providing the health care that formerly nurses and doctors provided. They're also lacking in preparation. So if we look at the intervention studies that have been conducted to help move along the support we provide to family caregivers, what we find that less than 10% of the interventions involve basic skill training. So interventions aren't even providing the basic skills that they need. They're not providing complex or care coordination. So we all know now it takes a lot of paperwork and a lot of phone calls and a lot of mapping to coordinate a family member's care. Most of the interventions have a single focus. They're not multi-component, and obviously most care recipients have multiple needs. And again, the interventions are focused primarily on white, non-Hispanic, highly educated caregivers. So there's much more we need to do, speaking to the cultural questions that were raised in that panel discussion. So caregivers are also often marginalized in the advanced care planning process, and we all talked about, and the mantra is involve your family member often. I think you really stressed that these are repeated conversations that need to happen. But also often to a patient, they think in terms of shared decision making. They think I've handed that to my doctor, and now we've shared. He or she knows what I want. But really, the family member needs to be involved in that. That needs to be shared decision-making quite broadly. The ACP clinical and research focus has really been on the caregiver understanding the patient's wishes, not on the caregiver's willingness and ability to carry out those wishes. And so we can't do advanced care planning just focusing on the patient because other people have to do the work of that. And we also know that when caregivers carry out patient wishes, they're either overconfident or underconfident, but they're often inaccurate. Again, because I think one of the things that was really valuable in the panel that we had is that we need to focus on helping families to engage in ongoing, meaningful conversations about advanced care planning. So we talked about this value estimate or the price tag. That estimate is all about care recipient costs. It's not about caregiver well-being. And we all know there's an impact of caregiving on the caregiver. So certainly the caregiver's health status. 1/3 of caregivers today are in poor health. And that can come from not taking care of themselves. They're busy, they're burdened, they're stressed, so they don't take as good self-care, and they can also engage in more unhealthy behaviors. They don't make it to the doctor's appointment. They might smoke a little more, drink a little more. So caregivers' health is impacted by providing care. There's also a psychological impact, and certainly there are some positive aspects about caregiving. I don't want to say that there's not meaning in providing care, but they're also typically in the literature they're outweighed by the impact of negative emotional effects, such as it can go anywhere from being stressful and burdensome to clinical depression and anxiety. And 20% of the caregiving population suffer from clinical depression, and that's twice the rate of the general population. So it's a real problem. And then we know that caregivers have some financial impacts. So if they have to have reduced work hours, there's a loss of income, there's out-of-pocket costs for gas, travel, providing food, and costs related to their own increased health problems. So now I want to talk a little bit about, there's one of those colored arrows, that also isn't considered in the value estimate, but we really need to be thinking about is the interdependence of patients and family caregivers' health and functioning. I'm going to skip that slide. So there's certain pathways we can think about of health and functioning between the patient and the family caregiver. So on this top pathway, you see the care recipient's demands, so their health demands, their instrumental care demands, et cetera. That has a stress impact on the caregiver, and there's caregiver burden related to that. And actually, there should probably be an arrow coming down here. The caregiver is then impacted both mentally and physically by providing this care, by being on, by taking care of the care recipient, and that affects their ability to provide quality care. And therein lies the care recipient's health is affected. And so we have this cycle that, that you can see in this slide where, for example, there's some really new literature out that caregiver sadness and fatigue, though just that being, we're not talking about clinical depression here, is associated with spouse care recipients' higher medical utilization and Medicare care expenditures. So there's real healthcare costs to burden and stress. And we know that spouse frailty and depression are interrelated as well. We all know this in our own families. So if you look at these arrows here, the idea that family caregivers may not go on strike, but if their compromised physical and mental health not only increases their eventual health care utilization, it also compromises their ability to provide care, leading to the care recipient's health to decline, which then in turn further impacts the caregiver again. And we have this downward spiral or this reciprocal cycle that affects, and it's really leading us to a doubling healthcare crisis. So clearly transformation is needed, and healthcare, I'm speaking to the choir here, we need to move from person-centered to person and family-centered healthcare. We need family caregivers to be partners in the care team. We need to upstream caregiver engagement, not just at the end of life, not just in life-limiting illnesses. And we need to have meaningful family, ongoing ACP conversations. We also need to do a better job training and providing curriculum for clinicians to learn how to engage families. So I'd like to actually turn to some of our own work, my team's research in hospice care, and talk about family caregiving there. We have a series of studies where we focused on family caregivers in the home hospice setting. So those of you know that, that family is the unit of care in the hospice, and it's a team care model where there's a social worker, a physician, a nurse, and primarily the nurse makes and a chaplain that makes the most frequent number of visits to the home. But their charge and their mission is to take care of the whole family. Indeed, you often hear common phrases when discussing hospice care as it's family-centered. It really focuses on a family in transition. Listening is as important as talking when you're with the family. Yet our work and others indicate that this represents a clinical ideal that isn't always practiced in reality. And I was talking to someone who works in hospice, and we agreed there's much room for improvement to better support and educate hospice care teams so they can support family caregivers. And caregivers in our studies described, we focused first on hospice nurse support of caregivers, and they described this help from the nurse along a continuum, and nurses approached them in different ways. So a caregiver described a nurse as doing to, and doing to the patient. So doing to was seen as taking control and performing tasks without providing an explanation, treating patients or caregivers more as objects and tasks to be done. And really, I mean, that's important care, and there are times for that. There's certainly, I don't want anybody in the ER, I want them to do 2, right? That's what I want done there. But in home hospice, there might be some other things along the continuum that would be more helpful to the family caregiver. And just to stress, the family caregiver provides 24/7 care, whereas the hospice team comes and goes. So they're really responsible for the bulk of care and need that training to do it. They described doing 4 was described as a more relational orientation form of practice where they're performing care on behalf of the caregivers or the patients, but it's still one step away from fully involving the caregivers. And then they describe doing with as the most skilled and expert form of practice, where clinical care is carried out in a way that invites the family caregiver into the process. And a nurse doing with is seen as mentoring or modeling for caregivers, and it demonstrates the ability of the nurse making clinical care and clinical information available, accessible, and visible to family caregivers so that they can provide care when the nurse leaves or other care members leave. We've also found in I didn't go forward, did I? We also found then in our work that the communication often fails to operationalize skills for busy, overwhelmed caregivers. Okay, so these people are providing 24/7 care. They have a family member dying. They probably have family members and neighbors coming and going. They're doing things they've never done before in their lives. And so explaining things at a level that they can understand and while they're being overwhelmed is really a high-level skill on the part of a clinician. And so, for example, we found with medication and dose and timing that really it's important for repetition, for what we call teach back, to practice it, to help them develop a system. And this really takes time in communicating, which doesn't always happen and which isn't always available. So what do our findings from these hospice studies, a series of studies, tell us? Well, it's a little too late. So why should we expect the hospice team to engage the caregiver for the first time in medical care, right? If they weren't engaged upstream, if they weren't prepared upstream, then the hospice team cannot possibly make up for all that. It's too late to provide caregiving training if they haven't been involved earlier. We also, and this has been said before, we need to lengthen our hospice stays, refer families earlier so that, of course you have to do 2 when you have, a nurse has to do 2 a patient when they have the patient for 3 to 4 days. There's no time to teach family caregiver how to provide care then. Certainly advanced care planning could happen with this if we have these meaningful, frequent conversations with family members. And then many people in this room, like Tim and Christy, are working with provider communication training, and that's beyond physicians and academic medical centers. Really involving families is a complex way of talking to individuals. So we can talk, I'm really good at the one-on-one thing, but you start expanding that room and that gets really complicated with lots of different people having different issues. So there's less training opportunities for nurses and other disciplines, less opportunities for community and home-based care providers, and often that training is not focused on involving the family. So there's a lot these results have told us, and there's lots of things that we can improve upon. So another thing I'd like to talk about, I'm a psychologist, but I've made my home at the College of Nursing, which is a great place for me. And one question I'd like to pose is the nursing profession at the ready for this family caregiver health crisis. So there are 3 million RNs in the US. It's the largest profession in the healthcare workforce, and they spend the greatest amount of time interacting with patients and their families. And the majority of nurses are women, and many serve as family caregivers alongside doing their paid caregiving job. So is the profession of nursing well positioned to produce the knowledge to better support and include family caregivers and to effectively advocate for and lead for changes in practice and policy? So our team, led by Dr. Kristen Cloyes, we wanted to examine whether that's the case, whether that these nursing documents, let me just find my notes on this. These nursing documents, we looked at 10 nursing documents that have to do with curriculum, with practice, practice guidelines with policy, and we systematically map the language for evidence of family caregiving. And then we context coded that language to look for content and meaning. And we thought, if family caregiving isn't in nursing documents, and it's absent from nursing curricula and practice standards, then nurses will lack the knowledge to really lead this charge and to enhance the role of family caregivers with the healthcare teams. So what we found that surprisingly, there were few meaningful references to family caregivers in these documents. And when there were references, it was usually the difficult family, what to do with a difficult family. And this is surprising, as nurses are recognized as having this unique interest and expertise in family caregiving engagement. And so the purpose of this work is we hope to develop a set of caregiver-focused competencies for entry-level and advanced practice nurses, ensuring that these guiding documents acknowledge and address the role of family caregivers in the 21st century in U.S. healthcare. So if we're not preparing our nurses around family caregiving, we're doing them a disservice. We're not preparing them for the work that we really need to do to stem this healthcare crisis. So I want to end with how we can talk about in our own professional and personal discourse to normalize family caregiving. And I always hesitate to use the word normalize because there's really no normal. But think of it in terms of normalizing it within your social network or within your family. We need to think about family caregiving as family care exchanges that occur across the lifespan. Most of us will both receive and give care across the lifespan, often multiple times. And this occurs within generations, like spouse to spouse, sibling to sibling, or across generations from grandparent to grandchild and vice versa. And for many of us that are fortunate, unlike what Tim was talking about, it involves a network and people are able to divide and conquer. So we want to talk about this in terms of this is normative. Caregiving in our lives is not just at the end of life. It's not just in old age. It is all of life. So in this slide, I want to depict how we can think of it in terms of a lifespan approach. And I apologize, these are not colored arrows. So I failed in this slide. But the slide depicts social support or family caregiving across the lifespan. So the arrow in the middle indicates it's over the course of your family or your social network's lifespan. And on the top half, we can call that the health promotion trajectory. So that's really what we're talking about there is health behaviors, health maintenance, prevention, early detection behaviors, healthy living, and I would say advanced care planning as well. And then if you look at the bottom half, that's the caregiving, what we normally think of as caregiving, the traditional term for caregiving activities. So certainly the support of health behaviors, but disease management. And then again, following advanced care planning, the directives, and providing end-of life care. So let's look at person 4, and it should appear, it doesn't really come true, but person number 4 is gray, and the grayer, the younger, and the opposite of real life, the grayer, the older. But the grayer, the younger, the darker, the older, that's what that depicts. So you can see person number 4 perhaps is on the left-hand side there, perhaps, let's think of them as a granddaughter, maybe 35 years old. The dark arrow going down, she's giving full-on caregiving to her grandmother, let's say, person number 1. And then you see a little lighter arrow going to person number 2. That's just, she's giving health behavior, maintaining healthy lifestyle, getting whoever person number 2, perhaps her parent, because they're also dark, helping them, but not in full-on caregiving mode. Then as you move across the spectrum, you can see that there's more dark lines going down, so more heavy-duty caregiving as we get toward the end of the lifespan. And then you can be providing care for not only an older person, but a younger person. There could be quite a few older people here, as we know, in the more dark. So the reason that I present this slide is I want to encourage us to realize that caregiving is just a part of life. So for most of us, we'll do it often, and others will care for us often over the years, not just at the end of the life. And we need to think about it in those terms, and we need to talk about it in those terms and normalize it within our families and within our social networks. Many of us are worried about being a burden, but it's important not to avoid discussions just because we don't want to talk about being a burden. So we need to talk about how do we care for each other, how do we prepare ourselves to care, and how do we want to be cared for, and just accept it as a fabric of our lives. So I'm going to go through the caregiving initiative. So summary and almost time for lunch, not quite time for lunch. So what are the next steps in research, education, and intervention? Well, we really need to test models of person and family-centered care and more comprehensive models. We need to upstream caregiver assessment and engagement. We need to understand, are you willing, are you capable of caregiving, and do you want to be involved in this care and a member of the healthcare team? We need to further examine and understand these interdependent effects of care recipients, because you can see that as one person gets sick and the other person gets sick, and then it just creates a mind explosion of healthcare expenditures and of suffering. Family caregiving, families should often and repeatedly talk about advanced care planning with as many people as possible. And then we need to think about family caregiving across generations and across networks. We're caring for health and wellness, and it's a support and exchange. And finally, we need to focus on family-centered care training of clinicians at all levels and across all disciplines and healthcare teams. So these are wonderful members of my research team, and have worked with students and postdocs over the years. And thank you, and I think we're ready for questions.
Thank you. And the one theme that I found that sort of overlapped between both your presentations was looking at the patient-provider relationship beyond the healthcare system. So really looking at what happens beyond, I can't hear. So looking at the interactions between patients and families and the healthcare providers, not just depending on the 5 minutes that the patients come to your provider office, but how do they really live in their world, and looking at it holistically. So thank you for that presentation. We're going to open it up for questions now. So if you have questions, raise your hand, and we have our Comagin Health staff, Jeremy and Sandra DeBry, with mics to get your questions.
So this is primarily for Dr. Ellington, but happy to have either of you weigh in on this. And I find here in the United States, and really in Utah too, there's this notion of not depending on the government or outside forces, that it should just be the family and neighbors, et cetera, et cetera. But I know that there are other countries that are doing this so much better than we are, and it just seems like we're reinventing the wheel if we're not looking to acculturating our community and our society to rethink about how to accept outside help and to be more community-oriented in terms of helping caregivers. I think about other countries where you have community health workers that are working with families who are dealing with these issues, and it's just a given that you're going to have that healthcare worker come and help you walk through these things early on, like you said, not when they're in hospice, but early on when a person might be starting to dealing with either chronic conditions, or you just know that they're going to start going down that pathway. So just wanted some thoughts on maybe some models that you've seen in other countries that work particularly well.
If you don't mind, I'll start off. One model that is quite effective and comes from the UK is called Hospital at Home. And that's something, there's a version of that here called Huntsman at Home. I mention that because this involves bringing medical care and sort of flipping it. Instead of having those with chronic illness come to the ER when there's a crisis, we come to them, especially when there's an illness that's easily preventable. So for example, a straightforward case of a skin infection like cellulitis or pneumonia perhaps, there are protocols and you have appropriate patients who are sort of triaged. They go to the ER, they say, no, we can take care of you at the home. And the satisfaction goes way up and the cost goes way down. So when Dr. Lee was here at the youth, she was a big proponent of this and actually brought in someone from Ireland. The National Health Service in Ireland was a leader in this. This is happening in Australia and also in the US through a Center for Medicare Medicaid Innovation project in Mount Sinai and Hopkins. A guy named Bruce Leff at Johns Hopkins is leading this. So just one example, and this so beautifully ties in caregivers, because then the caregivers can stay at home and the recovery goes better. So hospital at home is probably coming to an academic health center and hopefully a community hospital near you.
I guess I wasn't necessarily thinking around the world, but all the community resources we have here. And I think when I've talked to caregivers, they don't, and we all have to do a better job at this. How do they access it? How do they find it? When they find it, how do they get responded to in the right time? And we've all talked about we don't want to duplicate services, but we really need to do a better job of I think many services are there, probably not nearly enough, but how do we make them accessible? And you're also speaking to the issue, and how do we make it okay in our culture to say, I'm going to call them and they're going to help me out here. So I think we have a lot of work to do of ease of access in addition to sort of cultural acceptance of getting help.
And just a quick this really well, and actually in many respects is far ahead of non-VA providers. So there's something called G-Help, which is a sort of a home-based geriatric assessment intervention system, clinical program, again bringing care to the home. So there are a fair number of models out there. If we're looking for universal health care, look no farther than the VA.
To follow on, and you were just saying, because I'm actually from England, but they have a system whereby if an emergency occurs, one of the husband or the wife is suddenly stricken ill very quickly, and the wife can call a number which isn't 911, it's another number that they know as familiar as that, and a paramedic comes first and makes an assessment of that patient or that husband. And before they decide to fully roll an ambulance and do all of the theatrics of taking them to the hospital. I thought that was really an assuring service that really is very cost effective and calms the whole family down, including, the partner who's trying to make these decisions. And it was really helpful.
There was a study done, just to comment on that briefly, that looking at sending out EMS to assisted living facilities for patients who had fallen. And the intervention was to do kind of the similar thing, have a protocol so that you wouldn't just knee-jerk send these patients to the ER. And they found that virtually all of these patients were appropriately not sent to the ER, thereby saving caregiver burden and delirium and all the hazards of hospitalization. So this has been successfully done. It just takes, we need your help as the policymakers and people in the community to look at this. There are evidence-based models out there. The next step is the dissemination and implementation.
So I only heard part of what you said, but it's what Deepti's talking about, is CMS is now in an application program for what they call ET3. It's a reimbursement program because EMS, we currently only get paid when we take you to the hospital. So our incentive is skewed to take you to the hospital, that's how we make money. But this new model is about assessing on scene and triaging you to either your primary care or an alternative destination like an Instacare or urgent care, or we have a how to say it, a relationship with a physicians group that then we shift from, okay, we've assessed you, now we do telehealth, and that physician can now bill for a visit, we can bill for our services, that determines this is what you're going, and they can just write a script, whatever it is, or refer you to someone. So that's the model that CMS is going, but it's a 5-year pilot program, so you're talking about 5 years from now. With that year 3, they start bringing in quality assurance measures, which EMS, a lot of agencies are not used to quality measures and meeting those measures because it's not something we typically deal with. But I can tell you in Utah, Gold Cross and Intermountain Healthcare are doing our own little pilot of this in southern Utah because we have one hospital system to see how it's going to work in Utah and then roll it out statewide, at least from our perspective as to private providers, to be able to do that because the hospitals know we see their patients more than they see them. And so that's something that is out there and it's going that route, but it's not the 100% total fix-all with what CMS is doing in reimbursement for us, because that's our problem, is we can provide the service, we just have no way to bill for it, so.
I was just going to mention in Colorado, when my mother was not put on hospice in March on her 91st birthday, the very next month she got sick, and I called her doctor to come out, and they said, well, we'd be able to get there by Tuesday. I said, she'll probably be dead by Tuesday. Is there any other option? They said, well, why don't you call Dispatch Health? I said, what's that? And they said, oh, an ER doctor got really tired of people just showing up the ER, and the 90-year-olds always ended up on the ventilator before we found out. So he formed a great Dispatch Health that actually sends a nurse practitioner and an EMT out to the facility. They checked my mom's urine, did a Chem 7, so knew her potassium, sodium, all this. Gave her a breathing treatment with albuterol. It was amazing because she had a nebulizer that had never been opened. But they put the box together, put it together, and had the medicine. So they treated her, and I got to Skype into this because she was in Colorado, I was here. And immediately she started feeling a little bit better. And the best thing the nurse practitioner said to me was, I know this can be very hard, but have you ever thought about hospice? I just said, all the time. And they said, well, I just need some recommendation. We tried to get her on hospice last month, but the doctor said it wasn't time. And the nurse practitioner says, it's time. And she gave me 3 hospice suggestions. That was a Friday afternoon. By Sunday, my mother was on hospice. My other brother came in and I got Skyped in for that visit. And then it was just a miracle that she was on. I said, well, hey, Rob, let me talk to my mom. And she said, she's playing bingo right now. She's fine. And I mean, it was right during my MPH. I was doing my final, my thesis, and all my presentation, and I was trying to do what are the barriers to advanced care planning for my MPH degree. Meanwhile, my mother was living it, and it was very interesting. But Dispatch Health, if we can get something like that, and Medicare paid for it all. Everything, and she got a chest x-ray, and then she was on the hospice for 2 months, and it was delightful. It was the best thing ever because she did not want to go back to the hospital.
Can you talk a little bit more about that with the HIPAA? One of you guys talked about that.
Oh, yeah, I was referring to, and we talked about that a little bit earlier about, we're so focused on patient privacy, and certainly that's important. But sometimes I think we don't understand that where and when families can be involved. And they need to be involved because they care for the patient. So sometimes they're excluded. And the example, what's the example about they couldn't, they could be talked to about substance abuse, but because people think we're so nervous about making a breach of privacy that we don't follow the guidelines. And maybe you can speak.
I don't have any
practice. Okay.
The rule is specific to an emergency or crisis situation, and it's been applied to opiate overdoses in particular. But if there's an emergency or crisis situation and me sharing as a provider with a family member due to an immediate threat to health, not they're unconscious and unresponsive part of their continued patterns, whether it's a suicide or anything, there's going to be a continual pattern of self-harm involved. I can share a limited amount of like, this is what's happened, they've overdosed, and I don't have to have their permission. If I give the person Narcan and they wake up, I can no longer share with the family member unless I'm still adamantly assess the fact that there's an immediate threat to health. Like the patient still has the capacity to make decisions. They can tell me, no, don't share anything with my loved one. But if I strongly feel and document that this patient has an immediate threat to health because they're going to go back in an hour and re-overdose or re-shoot up, whatever it is, then I can share with that. And that's one of the misconceptions that we have. But it applies, the rule actually applies to emergency and crisis situations where, as a healthcare provider, you can use your judgment, you just have to justify why you shared it. And it's that forward thinking of, this is going to be a continued problem. And that's where we go like, well, they're awake, they're alert, like I'm not going to share anything because I don't want to get in trouble. But it's a BS decision to make, in my professional opinion. It's like, we get to share because our job is not the immediate, it's the whole spectrum that we've been talking about.
If I may add to that, just I mentioned in the unbefriended discussion, the fact that it took a crisis to get the patient I was talking about where he needed to go. It seems like some of the regulatory policy barriers are sort of set up the same way. So it's just always this thing. Well, you can only share information if there's a crisis. Well, what about being proactive?
Sorry, I'm shifting the conversation just a little bit, but Dr. Farrell, I just wanted to say I'm so happy to see that you've chosen this topic with the adult orphans. I'm a long-term care ombudsman. I cover the region of Utah, Wasatch, and Summit counties. For those of you who may not know what that is, I'm an advocate for residents living in skilled nursing and assisted living facilities. And this is a problem we deal with in a huge amount. We're kind of down in the trenches where the person has passed the hospitals, and now, sometimes we've even had neighbors come and drop these people at nursing homes or assisted livings because they're self-neglecting at home. They have no families, they have, no friends and so forth. It's a huge problem, and I'm not sure I have a question, but as much as a statement, there aren't great solutions for these folks. In going around and talking to residents in long-term care, I've done my own very unofficial study, and about 25% of them report to me that they have no resources, meaning people outside of the facility. 1 in 4 have no family or friends that they can depend on. Very frequently, these folks have dementias or brain injuries, can't make decisions for themselves. So as ombudsmen, we're called in because the facilities can't do it either. And in the state, the only resource we can rely on, if the person doesn't have their own finances and can make the decision to seek out a professional guardian, is the Office of the Public Guardian. And they are so underfunded that they only take the most emergency cases where somebody has some imminent medical decisions that need to be made. But in the meantime, there are a lot of other decisions. Some folks we can't even get qualified for Medicaid because there's nobody who can bring in their financials and other information as well. I've dealt with situations where many of them become homeless. So any given month, I have 4 or 5 of these individuals on my roster that we're just trying to problem solve for, and they have no resources in the way of individuals. So anyway, I was just really, really happy to see this on the agenda today because it is a crisis.
Thank you. We should connect afterwards if you have a moment. So thank you very much.
All right.
Any other questions for Dr. Tim Farrell and Dr. Lee Ellington?
Hi, my name is Linda Eggbert, and I work with Comagine, and I'm a nurse by background, so, I've worked in hospitals virtually all my career. But I've had the opportunity the last couple of years to help my father through his end of life and what was involved in that. And Lee, just to your point about getting people educated about what things are, so I'm the only healthcare person in the family, and I know my siblings relied very heavily on me for, well, can we get someone to help him with his medications? What are we going to do when he falls and is unable to get up? And I learned a lot that I didn't know about those kind of available resources. But I remember so clearly my sister saying, isn't there a class I could take so that I understand what I'm supposed to be watching for? And it just, again, reinforced for me that if someone who has a pretty strong experience in healthcare and familiar with a lot of resources, I can't imagine how people without those kind of resources try and make it through.
If I may just make two quick comments. There's one resources that 211 has a lot of good resources. Another one is, I believe it's the Alzheimer's Association, if you have a loved one with dementia, and I think it's the majority of the caregiving is for those with dementia. You can call them and ask about how to manage behavioral symptoms, which can be really helpful, especially when it's hard to get through to a medical clinic. So just two ideas in that regard.
Oh, I'm sorry. Salt Lake County Aging and Adult Services has a caregiver support program, awesome program. So please call us anytime.
I just wanted to back that up. A lot of times, 211 is a great resource to go to, but oftentimes when it comes to older adult issues, they're going to route them to the county AAAs. And Salt Lake County does a marvelous job. They've got folks who'll go out and do evaluations and case management and really help set up needs and support. So I would really, advocate to utilize those services.
Okay. Any last-minute questions for our speakers? Okay. Join me in giving them one more hand. Thank you so much.